Hi, this is Mercedes Byrne-Klug. I'm with the University of Iowa School of Social Work, and I'm co-coordinator of the National Nursing Home Social Work Network with Bob Conley. And Bob Conley is with us today also, and will be leading the questions at the end of today's session. Bob Conley has 52 years as a social worker, 52 years of experience, mostly in administration and policy, and most recently at CMS, from which he retired. But he didn't completely retire because now he's the co-chair of the NASW Maryland Aging Committee. So Bob, thank you for your continued service to the field of social work and gerontology.
You're welcome.
It is my
Thank you.
pleasure today to have this presentation by Amy Restorick Roberts and Danielle Smith. Amy is a professor at Miami University in Ohio and has done some seminal work looking at the impact of staffing on nursing home resident outcomes. So how is staffing related to resident outcomes? Really important area and a very creative use of administrative data. And also with us today, we have Danielle Smith, who is at NASW Ohio, and she is the executive director of the Ohio chapter and has been for about 12 years. So with that, I'm going to turn this over to Danielle, and she'll be starting us off. Thank you so much.
Hi, everyone. We're happy to talk to you today about the important topic of really how policy, research, and practice all come together. So our presenters today are me, Danielle, with NASW. We also have Dr. Amy Roberts with Miami University. I am going to present first and talk about our role with NASW Ohio chapter in this project and our advocacy work in general. And then Dr. Roberts will talk about her research. And after she's done, we'll have a conversation about how we all can be advocates for regulation for staffing in skilled nursing facilities in our individual agencies, in our states, and with the federal government. So I am a social worker. I've been a social worker now for about 15 years, and I've worked for NASW for 12 years. And in those 12 years, I was in a different position. Before I was executive director, I became executive director in the summer of 2011. And shortly thereafter is when this story that I'm going to tell you unfolds. I think it's a good example of how all social workers, and really all of us in health and human services, need to be advocates in the policy arena for the issues that we face as professionals and the issues that our clients face. And that we don't necessarily need to be good content experts in this information to be able to make a difference. And certainly this story, I was not an expert. I was brand new to the position, and was talking to one of our members, and the member said, "Hey, I work for the Ohio Department of Health, and a rule has been filed related to nursing homes, and I'm hoping NASW can get involved." And really from then, it's been, I guess, like 8 years of learning about nursing home regulations, the role of social services in those settings, and the regulation that exists. And so over time, I've gotten my feet in this and become more knowledgeable about the topic, but I'm certainly not the expert in aging and gerontology. I think, though, I'm a good example that we don't necessarily have to have, all of this information to be able to make a change. So this story, like I said, begins in 2011. And the member presented us with a rule change, which is part of the administrative branch, the executive branch of our state government. And the state departments have the ability to pass rules that carry the same weight as laws that impact practice. And so the Ohio Department of Health was giving notice that they intended to remove a rule related to social workers in skilled nursing facilities. To take a little bit of a step back so we all have the same information, The federal government, through the Centers for Medicaid and Medicare Services, has a requirement for a social worker or someone similar to a social worker to be employed by a skilled nursing facility when there are more than 120 beds. So that's sort of the base that states have to meet. And then if the state wants to go above and beyond that requirement, they are able to. And so until the fall of 2011, Ohio had a requirement that those smaller facilities, those with fewer than 120 beds, had to have a part-time or a consultant social worker. And so that had been on the books for many years, but the state was proposing that removal. And so we got involved and wanted to advocate for social workers and those in similar professions to be mandated to be in skilled nursing facilities. And so we really took on a campaign and advocated to the Ohio Department of Health that the requirement be kept. And so the Ohio Department of Health had a public body that made decisions about rules. And so we were able to talk to that Public Health Council, it was called, to try to get them to stop the rule from being passed or to stop the rule from being removed from the Ohio Administrative Code. And ultimately, we were successful at convincing them not to take action at that time to remove the requirement. A big reason for that is a social worker was a member of the Public Health Council. And so that social worker was able to advocate from within to keep that requirement, which I think is a good example of why we all need to step up and be in those government positions, whether it's as an elected official or as board members within other branches of the government. And so they decided, the Ohio Department of Health, Public Health Council asked for the department to arrange for stakeholder meetings with NASW, with the state government that was advocating for this rule to be removed, and the lobbyists from the nursing home industries. And so we had that meeting, and a big point of the conversation was that I believed, from NASW's perspective, that it is imperative that a social worker or someone with a similar background be employed at a skilled nursing facility in any fashion, albeit in this case, part-time or consultant basis, to make sure that the psychosocial needs of residents were being met. And one of the most common pushbacks from the state and lobbyist was, why do we need this? And sort of the questions here I'm going to display on this next slide. So why does the government have to have a regulation for this? Why social workers and not a nurse? Or why not some other type of professional? Why does the state need to regulate that someone needs to look at mental health and community type of domains within a skilled nursing facility? And certainly there's a need for professionals of all types to be working in interdisciplinary teams at skilled nursing facilities. But the value of a social worker is obvious. I guess obvious in the sense of, it seems very obvious to us, but we needed more research to demonstrate that it wasn't just our opinion, that there were positive outcomes as a result of employing social workers and similar professionals to do that work. And so we ended up not having a lot of answers to these questions that are on the screen. There wasn't a lot of research that painted a picture that it was worth it for skilled nursing facilities to employ social workers, nor for the state to have a regulation. But we were actually successful in that moment to keep the Ohio Department of Health to retain that rule. And so for about a year, we were optimistic that it was done. And then the legislature introduced an amendment to our state budget to basically, through the legislative process, push that administrative rule out. And really the state was saying that they wanted to do everything they could to get rid of regulations on the type of staffing the skilled nursing facilities had to use. And so it's been a number of years now since that's happened. And during that time, after the rule change happened, or after the legislation pushed the rule through, Dr. Roberts at Miami University contacted me and said that she was working on research that sort of answered those questions that we were looking at, and wondered if we might be interested in partnering together. And so I am going to have Dr. Roberts join me now and talk about her research. And then after she's finished, we'll sort of wrap these two together of really how research and policy connect to one another, and how we can use the research that Dr. Roberts has found to make positive change in Ohio, in your states, and federally. So I will mute and take my video off, and Dr. Roberts, you are good to go, and I let you control the slides.
Hi, everyone. Danielle, thank you so much for all of that really helpful background information. So I think we are controlling the slides here, trying to advance. Here we go. All right, so my first order of business today is to share that all of the information that I will be providing is available, free and available to the public on the Scripps Gerontology Center's website. So what I will be sharing with you today has been summarized in this research brief, which is just a 4-page overview of a variety of studies that I have been involved in with 2 other colleagues. First, I'd like to acknowledge Austin Smith as well as John Boblis, without whose input in this process, as their economics background and their statistical expertise and access to various data sources, these projects would not be possible. And also, I wanted to acknowledge the support of the Retirement Research Foundation of Chicago that supported this work. But all of the information that I share will be available to you for download on the Scripps Gerontology website. And I'd like to go ahead and just give you a quick overview of their website so that you know what to look for. On the screen below, you'll see that there's a publications link, and that link is available to actually search a variety of information on long-term care, on caregiving, on chronic illness, etc., that might be helpful to you. So they actually have a searchable index where you can search by topic or by author name to be able to access a variety of research briefs and policy reports that can be helpful to practice. So at this time, I'm going to go ahead and mute my video and make sure that you can see the remainder of my slides. And I'm delighted to be able to share some of our findings with you today. Okay, so our research team really wanted to start off by trying to examine trends in social service staffing. And we utilized data from a couple of different sources, and these are national data sources from the Online Survey Certification and Reporting System, also known as OSCR, as well as the Certification and Survey Provider Enhanced Reports system that's called CASPR. And later we'll talk a little bit more about some resident information that we were able to obtain from the minimum data set. But first, let's talk about just the trends in social service staffing. As you can see, when we take a look at Figure 1, this describes nursing home staffing levels in 1998 and 2006. So this bar chart really allows us to compare the staffing of social service departments to other types of nursing home staff. And as we know, all types of staff are important in the provision of care for residents. If you take a look at the orange and blue line, you can really see that during this period, staffing levels for social services were lowest, and they also saw the smallest increase among all of the departments. But in contrast, the nursing staff that consist of registered nurses with administrative duties, registered nurses providing direct care, licensed practical nurses, and certified nurse aides had among the highest staffing levels and saw the largest increases over time. Now, we think that these increases are primarily due to advocacy efforts to increase nurse staffing and more stringent minimum nursing staff requirements. And as you can see, in the absence of stricter regulations to guide facility staffing decisions, the staffing levels of departments such as social services have remained flat. So this slide really helps to show that social services really has flat in terms of staffing levels within this time period. And we wanted to first understand what these trends were overall, but what we thought was probably most important to do is to think about, so what? Why does this matter? So if we know if social service staffing levels are low, we need to be able to articulate what value does social services have, what functions does it provide, and why does this matter in the scope of things. So the team that I had mentioned before, Dr. Smith and Dr. Bobliss and I set out to try to provide some relevant information to guide data-driven decision-making to influence policy and practice. Okay, on our next slide, we have a slide here that talks about, again, comparing social services with other types of staff. And so from our next step in this research is to really think about, why does social service staffing matter? Well, we wanted to consider this from a provider perspective. We wanted to think about what would provide a compelling argument for a provider who has limited resources in terms of helping to guide decision-making about what could potentially bring the most bang for the buck, as they say. In what ways can we provide recommendations to help facilities be as cost-effective in their decisions, but also making the most efficient choices. So in nursing homes, quality is commonly assessed through the number and severity of deficiency scores that a facility receives during an annual recertification survey. So in this study of the cost-effective adjustments to improving nursing home quality that was published in Medical Care Research and Review, we examined which type of staff improves quality the most per dollar invested, and found that nursing homes can expect the greatest value from their investment by increasing the level of social service staff. So Table 1 shows that quality improvement for various types of staff are different if we sort of compare this to social services. So it's important for us to think about ways that we had to adjust for differences in wages, as well as the effect of which type of staff has on deficiency scores. And clearly, every type of staff makes a difference, and all types of staff are important. But what we found in this research is that every other type of staff reduced deficiency scores less effectively than social services did. So from this study, we can make an argument that nursing homes who are interested in improving quality in the most cost-effective manner should consider increasing the level of social service staffing. Our next slide talks about how higher qualifications of social service staff improve resident outcomes. So whereas we were talking about the actual staffing levels in the last slide, here we're talking about the qualifications of social service staff. So nursing homes do have a lot of flexibility in terms of who they can choose to hire to provide nursing social services. Federally, as Danielle mentioned, there's a guideline for qualifications of social service staff that applies to nursing homes larger than 120 beds, which mandates hiring at least one full-time qualified social worker that we also call a QSW, because these federal guidelines really broadly define what a QSW is as a person who has obtained at least a bachelor's degree in social work or a related human service field. So that means that a person who is working as a QSW need not have a degree in social work or a social work license to be considered a qualified social worker. So nursing homes may also hire individuals who do not have a bachelor's degree in human services field, but they are responsible for providing some medically related psychosocial care that we refer to as paraprofessionals. So because of this variation in the educational background and preparedness of social services, we wanted to next examine whether these qualifications of social service staff matter in terms of resident outcomes. And some of the results that I will share in this section are drawn from the JAMDA article about nursing home social services and post-acute care. So in terms of some of our major findings in this category, we did examine traditional Medicare beneficiaries in a nursing home for rehabilitative services after a hospitalization. And we did find that the quality of care was higher when QSWs were employed compared to paraprofessionals. So the more QSWs reduced the presence of behavioral symptoms, including rejecting care and wandering, and residents were prescribed fewer antipsychotic medications. So whether behavioral symptoms are directed towards others or self-imposed, these behaviors can interfere with the care of a resident and place him or her at risk for social isolation or injury. The other information that supports this idea in terms of higher qualifications of social service staff improving resident outcomes, we've found some preliminary trend data that suggest that traditional Medicare beneficiaries are more likely to transition back to the community after a short-term rehabilitative stay. So we haven't published these results yet, but I wanted to share them with the listeners today to be able to, again, provide more evidence, at least suggestive evidence at this point, that more qualified social service staff does matter, and that higher qualifications are related to making a positive impact on older adults' overall health and well-being. Okay, so we also took a look at how social service departments overall are staffed, including the proportion within a staff of those who have obtained a QSW and those who are paraprofessionals. And as we have noted, federal regulations require that nursing homes must provide medically related social services and to attain or maintain the highest practical physical, mental, and psychosocial well-being of nursing home residents. So it's something that we wanted to take a look at because there really are no federal minimum staffing level requirements for social services beyond the more than 120 bed threshold that requires one full-time QSW. So some states do have stricter requirements. Most states follow the federal guidelines when it comes to staffing qualifications. So consistent with these federal regulations, you can see that if we look at the 90 to 120 beds and then the 121 to 149 beds, we see a big jump in the proportion of departments that do have more heavily staff weighted towards the QSWs. So that really helps us to understand more about how this is consistent with our federal regulations, that there is a significant increase in the employment of QSWs in nursing homes with more than 120 beds. But at the same time, staffing levels for social services are low across nursing homes of different sizes. So efforts to increase these social service staffing levels and qualifications may require advocacy for stricter regulations. So I think at this point, I'd like to go ahead and turn the presentation back over to Danielle that will talk more about spreading the word.
Great, thank you, Amy. So I think Dr. Roberts did a great job of really illustrating why we all need to be activists for these issues. Certainly nurses and other professional groups have taken their empirical information to policymakers, to the owners or management of facilities and said like, hey, look, here's why it's important to employ us. And as social workers, we have to do the same. And certainly in other similar professional groups, we have this data that shows our value. It shows the contributions we make to clients, and that it's worth doing something with it. I know that probably a few of you are like, oh, politics, I don't like to get involved. I understand that perspective. It can be really challenging to work with our legislature, but I encourage you to do so. It's important for our profession and it's important for those that we serve. So after Dr. Roberts finished her research, she contacted us about how we could get information out to other social workers and to organizations that could do advocacy work. And so she connected to NASW, and we have a chapter in every state and territory. So we are able to communicate information out on how social workers can take action pretty easily. And so the screen shows a section of an article that our national magazine, Social Work Advocates, published about Dr. Roberts' work and the collaboration that she did with the Ohio chapter. You can check that out at the link at the bottom. It's accessible to NASW members. And NASW is a really good place for you to begin your advocacy work. Even if you're not a social worker, so our association, NASW, is concerned about these requirements for social workers and social service professionals. So certainly we would be interested in carrying this work for you. I we do quite a bit of advocacy work on a state level here at the Ohio chapter. And in a second, we'll talk about ways that you can take action on this issue where you are. So there's a couple of different ways that you can be an advocate, right? We typically think of the government as really the only source of our advocacy, or the only target for our advocacy. But there's lots of different levels and players in this work that you could approach. And, really, it doesn't have to be a massive campaign sometimes. It can be a letter or just a conversation that can prompt a lot of change to happen. And so the first thing to consider is if you can be an advocate with the agency that you work. So Dr. Roberts' research really presented a good business case of why it makes dollar sense to employ social service professionals. And so agencies are typically looking for ways that they can get the biggest return for their dollar. And we have hard evidence that shows that we are the best investment source within a staffing situation through Dr. Roberts' research. So it would make sense to maybe schedule time with the managers of your agency to talk about staffing configuration, or at least to present this information, because agencies are often going to be looking for ways to save dollars and make an impact. There perhaps are policies within the agency that you could affect by mandating sort of a similar ratio just within the agency itself and not by the government. And then obviously the government is the most likely place that you can take action. So the federal government is setting that requirement for the larger nursing homes through CMS regulation. And there's points of advocacy there that could happen. So, maybe perhaps the federal government could have a requirement for the smaller facilities, or they could do more to reimburse for the cost of social service professionals in those settings. Certainly a related issue that's happening right now is the CMS is proposing a reimbursement rate cut for social workers. And so that, causes issue, not so much in the skilled nursing facilities because of other legislative problems with that NASW is working on, but in the context of aging and social work, that's an issue where you could take action now. The comment period just finished for that, but there are ways that you can certainly contact our national NASW or CMS itself. I am an advocate for being more involved on a state level, both because of my job, but then also because prior to working for NASW, I worked for the Ohio Senate, and it really exposed me to the depth of the decisions that they are making. They're often going unnoticed. We pay quite a bit of attention to Congress and the president, but very few people know who our state legislators are and what they're doing. Sometimes when I present this to classes of social work students, I'll talk about state legislature and ask for people, ask for someone to raise their hand if they know who their state rep or state senator are. And most of the time, very few people do when I ask that question. But they are making decisions that impact us every day as social workers, as social service professionals, and the clients and communities we live in. Some research was done that shows that the state government has more impact on our daily lives than at any time prior to, more so from the 1960s than any time previously. And so they're making decisions like the state regulation I mentioned at the beginning that impact our lives and our communities. And so it is important to know who those people are and to reach out to them. So I think here I'll pause. Merce has a document of all the state regulations, if you don't mind sharing your work on that, because I think it's a good overview of where you can check to see if you can take advocacy action on creating a state regulation or preserving the state regulation that you may already have. So I'll pause there, Merce, if you'd like to talk about that document.
Sure. Thank you, Danielle. In 2018, a group of social work students here at the University of Iowa and I reviewed all the state administrative codes to see, sorry about that, to check to see what the rules were regarding nursing home social service qualifications. As Amy and Danielle both said, we have federal regulations that all Medicare and or Medicaid certified nursing homes, if the nursing home has more than 120 beds, then that nursing home is required to hire one full-time qualified social worker. And according to the federal government in nursing homes, the qualified social worker is somebody with a college degree and 1 year of experience in social services. So the students and I wanted to know, well, what about the nursing homes with fewer than 120 beds? The federal government rules are silent on nursing homes with fewer than 120 beds, with one caveat. The federal regulations say that all certified nursing homes have to meet the medically related psychosocial needs of all residents. And the nursing home can meet those needs by hiring a staff member to meet those needs, or contracting with somebody to meet those needs, or contracting with a local agency. So whether or not the nursing home hires somebody, the nursing home is still held responsible for meeting the psychosocial needs of all the residents in that nursing home. If the nursing home has more than 120 beds, they have to hire one person with a college degree and some experience in social services. But as Amy said, that person does not have to be a licensed social worker according to the federal government, and does not have to have a degree in social work. Nursing homes are the only setting where federal regulations have this unique definition of social worker. In all other federal reimbursed settings, the social worker has to have a degree in social work and be licensed. Anyway, so we went through the parallel process for states, the parallel process to the federal regulations. So every state has a legislature, and the state legislature can pass bills, and then the bills go to the state agency that has responsibility for that content area, and then the state agency puts in more details about the bill. So administrative rules. So we looked through all the administrative rules for every state to see what was said about nursing homes with fewer than 120 beds. In other words, do states have rules about the qualifications and or presence of a social services person in nursing homes with fewer than 120 beds? And our results were really interesting. First of all, 12 states did not even address the nursing home social services at all. And so, as Amy mentioned, if the state code does not address an issue, then the federal code prevails. So the federal code of federal regulations then prevails. And states can make their own state laws more stringent than the federal laws, but they can't make them less stringent. So in 12 states, they don't say anything. And so the federal rules apply. Through our analysis, 25 states were out of federal compliance. So 25 state administrative codes said something different and at odds than what would be allowed by the federal government. We had 8 states that did a pretty good job, and Maine did the best in terms of looking at the qualifications of a social worker and whether or not social workers needed to be hired and under what conditions. So the state-by-state summary was published. It was published in an article in the Gerontologist. I'm the lead author, last name Vern Klug, and it was published in 2018, and it's available online. And if you have any trouble getting it, just contact me through the University of Iowa, and I'll send you a PDF of the article. But Danielle is right on target. These are opportunities to look at your own state code and see if you may need to be strengthening the state code to ensure that residents in your state's nursing homes have access to a staff person who's been trained in psychosocial assessment, psychosocial care planning, advocacy. There's a lot of important things that social workers do in nursing homes, and we think that residents would benefit if they had access to them. So that's all I have to say for now. I'm going to turn it back to you, Danielle.
Great. That's a really good resource for you to not have to dig through your administrative code yourself to take a look at what's there. And one thing that was mentioned that we talked a lot about when we were working in Ohio is, to have a requirement that says psychosocial needs must be met and perhaps, have assessment data that will measure that. That's a lot less concrete than saying you must have a staff person trained in this. And that was sort of an excuse used by our state to say that we didn't need a staffing requirement in Ohio because there was this general requirement that psychosocial needs needed to be met. But, in my limited knowledge area, it seems though that the assessment might not be able to pick up on every element of psychosocial needs, that if a social worker or a social service professional was involved, they would notice, hopefully would notice. And so, relying on something that doesn't necessarily have the staffing in place doesn't seem to me to be an overly effective way to make sure that that is happening. So, it's one of the sort of debates that we had in Ohio that potentially could come up with you as well. So, like I said, there's lots of ways for you to take action. These are all things for you to perhaps have discussions with peers about action that you can take in Ohio. A couple of things I will note here. One is that really the requirements for advocacy are pretty minimal. I would really just encourage you to take the first step and to see where you go from there. I think it can be a little overwhelming to think about this issue in its entirety, but know that you are the expert. You certainly know more about issues pertaining to aging and psychosocial needs than most legislators will know, and I wouldn't be intimidated by the process of engaging with them. And like I said, you can group up with your peers and find other people who want to help on these issues. NASW is a good example of how you can group with your peers to take action. I'm going to ask Bob to talk about his role with NASW Maryland because it's a good example of structures that might exist in your state to help you with this work. Bob?
Danielle, do you want to stop sharing your screen and then our faces will be bigger for a discussion?
Sure.
Thanks. Okay, thank you. And Bob, do you want to, or
yeah,
I can do that?
Can you hear me?
Yes. I'm going to see if, I think you're going to be, okay, now we see your ceiling, Bob. Good. And now you're muted, so let me see if I can maybe unmute you. You'll have to unmute yourself, Bob, please.
All right. Can you hear me?
Yes.
Can you see me?
Yes.
All right. So as I mentioned, as Merce mentioned in my introduction, and I really want to support what's said about doing advocacy in your state by Danielle, because in Maryland, we have a committee on aging that has about 20 active members, and we go out to about 80 people. And we're trying to kind of track not only legislation, but also rules. And one of the things about nursing home, and it's been discussed on this call, is there is this 120 bed rule that has to have a social worker. And there is also this federal statute that also says that you can be human services or MSW, BSW. But in Maryland, there was a review of the regs that come down from the feds, and I had worked as a fed. It's first published at a federal level. Merce and I and other social work leaders tried to change it. We weren't successful, but we pulled together a document that really provided clear reasons on staffing and on policy to have a licensed BSW as the minimum. So in Maryland, both the Board of Social Work Examiners and NASW came together and they advocated with the Department of Health and Human Services, and they've changed the rule effective 2021 that now will require a licensed BSW or MSW to be in all Maryland facilities. And the interesting thing is the state level can't make this change without doing an analysis. So I'll just look away for a minute. And their survey found that of the 229 licensed nursing homes, 75% or 172 nursing homes needed to hire a contract to get a minimum BSW or MSW licensed person on staff. They're not going to fire the people that are in there, but they'll just be grandfathered out. And this salary range meant that the state has to allow $11,000 more for the facilities to bill, and that comes to a cost increase in the state to get those additional social workers be licensed at a BSW or MSW to $1.892 million. So when you get into these rules, it really has to follow up with dollars. So in Maryland, we're pretty enlightened. Our board is pretty enlightened. There's a requirement for licensure. So it's now a done deal. And I guess I just want to encourage people out there, if they want to write me or Merce, we can perhaps give you some documentation that as you see that reg come down, you can comment on.
Now, Bob, did you say all certified nursing homes in Maryland, regardless of the number of beds?
Yes.
Wow.
I don't think it changed the 120 bed rule. It didn't change that. We asked to change that. And what the state said to us was that their survey process assures that good psychosocial care is being monitored. And we weren't happy with that idea, but we're going to get some of our practice social workers together to kind of help us look at that and look at surveys when there isn't a social worker and it's under 120 beds. But we weren't successful with that. But with all the over 120 bed are going to now have a licensed BSW or MSW.
Okay.
And that's a great example of how you can take action on the state level. We did, the last time we talked this webinar, we had a few people who were from more rural conservative states, I think with a similar political makeup as Ohio. And so that to me seems like a dream right now to have something like what has happened in Maryland happen here. But you can definitely frame, I think, this argument with conservative legislatures in a way that makes sense to them. When you talk about the business case that Dr. Roberts' research presented, that hopefully with that investment of state dollars, that in the long run they would see savings both to the state and to the individual agencies. And so it is important to think about the political nature of the body that you're advocating to and see how you can frame your argument in a way that really appeals to their interest. And I certainly think Dr. Roberts' research is an effective way to do that.
The other thing, Danielle, I'd add is that if your state has social work licensure and it requires people in nursing homes to have a license, then you could perhaps go to your board and say there's a case made in Maryland that has licensure that's been able to change the federal rule within their state, which you usually don't hear about. But if you have a precedent, sometimes it might allow you to talk to your legislators or talk to your board.
And I'm sitting here in the School of Social Work, and so we need to make sure at schools of social work that we're preparing the next generation of long-term care social workers, and that we are recruiting more students into the program who are interested in working with older adults and on older adult issues. and then making sure that they've got the experience and the skills that they need to not just survive in a nursing home, but to thrive in a nursing home. Because when that social worker is thriving, the residents and the families are too. That social worker may be the only person, the only staff person on site who's had any training in psychosocial care and psychosocial assessment. So it's a very important position for resident quality of life. And also the social workers often work with families who are needing to better understand the situation that their loved one is in, or better understand the system of the nursing home. So social workers are, there's plenty to do for the social workers that are highly motivated and also have a job description that encourages them to really do the social work. Anything else that anybody would like to say before we close?
I had a question for Amy. I've always heard that CMS data, I worked there for almost 20 years, was difficult to work with. It seems like you and your colleagues have been able to use it and look between the MDS, the nursing home data, and all the other data sets. And you also said that you were able to compare that to nursing home deficiency scores. And I wondered how that worked for you. And secondly, how did you look at deficiency scores? I know there's severity changes, and there's some of them that are qualitative and some of them that are more clinical. And I wondered how you were able to do this excellent work that you did.
Oh, thank you for that question, Bob. So I was very, very fortunate to be linked with a faculty member in the economics department, John Bobliss, who has done a variety of research on nursing home quality. And so he is really an excellent methodologist who is quite adept at bringing different data sets together. But what you're talking about is really important in terms of thinking about how we measure different things. And it is absolutely wonderful that we have access to some national data to be able to understand more about some of the relationships between social service staffing and quality outcomes or resident outcomes. But at the same time, we have to think about how these things are measured. So you asked specifically about the deficiencies. So in that research paper, we actually looked at the number of deficiencies as well as the severity of deficiencies. Right. That is based on how CMS measures any deficiency concern that is obtained through the recertification process by the surveyors. But you are correct in the fact that there's certainly a lot more to know in this area. And as we've been talking about today with this issue of how a qualified social worker is measured, it does complicate things in terms of being able to really say it is the social work training and educational preparedness and licensure that's making the difference. And so one of the really exciting projects that is upcoming is some of the research that Dr. Byrne-Klug is leading in terms of actually surveying directors of social services and nursing homes so that we have a better understanding from within the social service department exactly what does psychosocial care look like. And from this information, we do have some future studies planned so we can take a look at the CASPER data for facility characteristics and staffing levels, as well as looking at MDS data and potentially looking at some of this national data from social service directors to be able to kind of take all of this information together and really try to focus in on impactful outcomes to try to be able to better inform policy and practice. And so with the study that Dr. Byrne-Klug is leading, we're going to be able to work together on understanding more about the role of the social worker in the nursing home, how different departments are configured, and does this make a difference in terms of resident outcomes or the quality ratings of a facility? So I'm really excited about that next step with this research.
And we had 922 nursing home social service directors from around the country who completed the 200 questions. It was quite a hefty survey. And that project was also funded by the Retirement Research Foundation. So I want to give a shout out to them for funding both Amy's project and my project. And we have people from around the country who are going to be helping to analyze the data so we can get it out quickly. And Amy and her team will be looking at the relationship between social service directors in more detail than we have from the federal data, from the social work data, and then outcomes, resident outcomes. So, well, I want to thank everybody so much for joining us. Danielle, keep up the great work. Bob, keep up the great work at the state level. And Amy, I know you're going to keep publishing and keep involved. So thank you all. And if anybody has any questions, you can contact me through the University of Iowa, or Amy through Miami University, Danielle through NASW Ohio, and then Bob through email. Oh, here's their Amy and Danielle's email. Good.
Thank you. And we absolutely would love to hear your ideas and suggestions. So please don't hesitate to contact us if you have any questions or research project ideas that we could collaborate on.
Great point. Good. Thank you, everybody, and goodbye for now.
Okay.
Thanks.
Bye.